A stabbing rampage at a local mall last week confounded everyone because of its senselessness and sheer brutality. How could something like this happen? Then we learned the suspect, Arthur DeRosa, had actually sought help at Morton Hospital in Taunton for depression and psychotic delusions and was released early in the morning on the day of his attack. His family spoke out, charging that the healthcare system had failed him.
The ambulance picked him up at 5 p.m. on Monday. They discharged him at 4 a.m. on Tuesday. They didn't treat him for what his sickness was or his mental illness. They treated him for something else.
One of the big questions is whether a system that requires a third-party contractor do a mental health evaluation for a mass health patient actually contributed to DeRosa's untimely release. Now the state is investigating whether the hospital made any mistakes in the way they handled this case.
This was a horrible, terrible tragedy, and emotions are running high, and there's a lot of information out there, and the thing we need to do is figure out exactly what happened and why, and then make adjustments based on that to make sure that it doesn't happen again.
Joining me are Robert Mendoza, a neuropsychologist with Boston Forensic Associates, and Donna Mosh, President and CEO of the advocacy group Massachusetts Association for Mental Health. Thank you both for being here. So let me ask you at the outset, when an individual goes to a hospital in acute emotional distress, what are the range of care options that are out there? What could happen in a situation like this?
Well, first of all, we don't know how a person gets to the hospital. If they're there under an involuntary section for evaluation, once they get to the hospital, they have 2 hours to be evaluated there at the hospital to determine what might or might not be necessary. If the person goes voluntarily, there might be a little bit more window of opportunity before evaluation takes place. Once that evaluation takes place, a determination is made, usually with an outside, whether within the hospital, but someone from psychiatry, social work evaluates the person, determines what might be necessary, consults with the attending room physician, and they make a determination about disposition. That's the theory. There are some, obviously, things that are different if the person has Medicaid or the time of day, et cetera.
Let me ask you about that Medicaid factor, because I had no inkling that there is apparently this two-tiered system in Massachusetts, where if you have private insurance and you go to a hospital seeking mental health care, you are treated by the hospital's staff, and if you go and you have Mass Health, you're treated by a third-party contractor. Why is that the way we do business here?
Well, I'll speak about Mass Health. Part of the array of services or benefits that a Mass Health member has is crisis services. And crisis services includes a number of things. It includes assessment. It includes, in some cases, diagnostics if a person comes in and hasn't been prior diagnosed, and then a determination about what would meet the immediate needs of that patient. That might include some intensive further evaluation or workup. It might include some intensive outpatient services. It might include referral to a crisis stabilization service, or it might be determined that the best service for the individual's needs is inpatient admission.
So just so I'm clear on this, how does the sort of a coterie of treatment options or treatment complements that you're describing, how does it compare to what an ordinary privately insured individual would have at their disposal?
Well, first of all, we described to you the theory.
Yeah.
What happens at hospitals is really very different. At large metropolitan hospitals versus some of the community hospitals where they might not have the staff members. For instance, I was speaking to a colleague today who actually runs one of the services at a large hospital here in Boston, and their process is really quite different. If someone comes in, they have their person within the hospital evaluate that individual, whether or not they have Medicaid or not. If they have Medicaid, they only use the emergency services team for assistance in providing access to care. They do
and
not
the emergency
rely,
services team is the third-party contractor,
right? But
right?
they are not relying on them to give the primary assessment. They are using still their own attending and training staff there at the hospital. They are not relying solely on that third party. Unfortunately, in smaller regional hospitals, they might not have access to that.
That's correct. Those hospitals may not have psychiatric staff to do those assessments, in which case the team provides that. The other thing is the team provides access to a broader array of services. I will also say that some private insurers do elect to contract with the emergency services team to to provide access to a broader array of services.
Just so I'm clear on this, because I may be thinking about this incorrectly, if you had a loved one going in to get emergency mental health care, would you want them cared for by an emergency services team or by the clinicians at a given hospital? What would your preference be? Because it sounds like you're saying the former might be a better option.
I would want them to have access to a broad array of services and a determination of what would best meet their needs. Now, it's quite possible that the hospital's clinicians could make that same assessment and could make a determination about need. They might not have the same level of authorization to direct people to care that's funded by Mass Health that the emergency services team funded by Mass Health is able to access.
So it could actually be more beneficial to someone to be going in with Mass Health insurance and getting their care through the emergency services team.
If you have Mass Health and want to be directed to those other services, that's the path.
There's a statement that we should get in here from Morton Hospital, which strongly suggests, and obviously there's a blame game going on here, but they seem to be arguing that this system, the emergency service team system with Mass Health, is part of the problem. The statement says the current policy mandating that the evaluation process must be carried out by a third-party state contractor is misguided. So obviously they have their take on what went wrong. They want to point the finger at the emergency services.
Sure, and we don't know what happened from the moment that person arrived at the emergency department. Right. We would want to know what chain of events occurred. However, no matter what the emergency services team said, an emergency room physician would have to have agreed with the disposition. If that emergency room physician felt that the assessment was to let the person go, the emergency services team said, we're going to let them go, we don't think they need to be hospitalized. There is an appeal process that emergency physician room could say, I don't know that I agree with that, and they can appeal that process. I guess what I'm suggesting is somewhere along the way, the hospital had to have been in somewhat agreement with the decision that was made.
I'd love to hear from both of you, starting with you, Donna. Is it conceivable to you that an individual could go to a hospital in a state of duress, so much duress that they wanted to get help, and then over the course of 9 hours present in such a way that a clinician could responsibly say, whoever it was, whether it was this emergency services team or someone on staff at the hospital or both, could they then, over the course of 9 hours, come across in a way that a clinician could responsibly say, I think they've got this under control. We've talked to them about their anxiety. We've talked to them about their depression or suicidal ideation. We are going to discharge them, and that's the responsible thing to do. And then have the individual turn around and lose it, like Arthur DeRosa did. Is that?
Yes, in theory. That's certainly possible. Decisions like that are made every day. People go into the emergency room every day and say, I'm thinking about harming myself or somebody else. Most people don't end up necessarily getting hospitalized for those kinds of things. But I think, and again, you and I have had this discussion many times, this is a very low prevalence rate event. These things don't happen very often. Thousands of emergency room evaluations take place with no bad outcomes for the most part. However, there are certain things that we do know that do contribute to more complicated decisions about releasing somebody. So far, the information we have about this case raises an enormous number of red flags. He was hallucinating. He was believing that someone was going to poison his children's mind. He thought that the devil was speaking to him. Others described him before and after the emergency room physician evaluation as manic. People described him as depressed and suicidal. He had a history since 2007 of violent events and threatening people. And there was a question about substance use in his past. Those are, as we've talked about before, when you have those red flags, I'm not sure, assuming all the information is correct, that's somebody you might want to let go without being adequately assessed further.
Donna, what do you think? Do you come down in the same spot as Robert?
Well, I'm not familiar with this gentleman's treatment history or diagnostic history. I have seen a number of cases over the years, in my years in serving in community mental health programs and in state government, certainly seen emergency services able to resolve acute symptoms with the provision of medication in a number of hours. And in this case, we don't know whether the clinician felt they had resolved these symptoms and therefore discharged the individual based on the fact that perhaps they received medication and after some number of hours were no longer expressing suicidal ideation or expressing some of the other delusional statements. Again, we've heard these statements made by other parties who are not in that clinical evaluation. So it's difficult to have an opinion about what happened with this gentleman.
Are we going to get a fuller picture, by the way, at any point? Because I know there are privacy guidelines. To a layperson like me, it seems like those guidelines should be waived or softened if an individual, goes on a violent spree and ends up losing their own life. But maybe I'm wrong. Maybe that's not how it works. Will we learn what happened in the 9 hours that Arthur DeRosa was there at Morton Hospital?
My understanding is that there are parallel investigations going on. There's a criminal investigation that's looking into what happened due to the outcome of the event, the loss of life. And my understanding is the Department of Mental Health is doing its due diligence about looking at the process from the time the person arrived there. And if in fact, if the family is reporting that they said these things to the emergency room and the emergency room was aware of these, how did the emergency room person make a determination from that point going forward? So they're going to look at that whole process. I think that we will have a better idea about what happened.
The Department of Health is also investigating based on its authority as the licensing agency.
Well, I'd certainly want to know if I was a family member of one of the victims. You'd want to find out. Donna Mosh, Robert Mendoza, thank you both.
Thank you.